Now we start the second talk about the Milan system for reporting salivary gland tumor. I will give an overview and some updates. I'm Mark from Taiwan, and thank you for Thailand Society, especially President Song Poon's kind invitation. And I'm very, honored and very happy to join this pathology master section, especially with Dr. Dan and Dr. Japanese anyway, Junya, yeah, Dr. Junya. And after my talk, maybe Dr. Junya would go on the long series and Dr. Dan will go on the breast series. And this topic too will focus on the salivary gland tumor. And I also disclose no conflicts of interest. And then I also want to congratulate with the, the Thai people, doctors, you very excellent to submit cancer cytopathology and diagnosis cytopathology to participate in the editorial board of these two active cytology journal. I welcome you to submit your manuscript more and more to cancer cytopathology and to diagnostic cytopathology and also to cytopathology, the British cytology journal. We welcome you to submit. And if I am the reviewer, I will be kind to your submission. And outline of this talk will be first introduce the salivary gland tumors, and I will mention some updates of WHO fourth book because our Milan system is associated with the updates. And then the major comments and major introductions will be on Milan system reporting, and I will introduce two of my interesting cases. This talk will be much longer than the previous talk because the salivary gland tumors are a very complex and big topic. First, we need to introduce salivary glands. Before we approach salivary glands, we should know they are major glands such as parotid glands, submandibular glands, and sublingual glands. And also, we have lots of minor salivary glands, especially on the roof or the mouth, the lips, the tongue, the cheeks, nose, and parasinuses and larynx. So these areas can have salivary gland type tumors. And tumors in minor gland are uncommon, but mostly they are cancerous. And as the Thai people, you have published the large case series of salivary gland tumor. And in your population, you can see most of the neoplasm are parotid gland, on the parotid gland, and then submandibular glands, and then the oral minor gland, and the fourth, the sublingual glands. So parotid and submandibular still, the most occurrence sites. About the malignant rate, the highest malignant rate is always on the minor glands and sublingual glands. So about the parotid, only 20% malignant cancers. And how about the neoplasms? Most of the benign tumors are pleomorphic adenoma, and then come with the second Warthin tumor in your population. And about the malignant tumors, the most common is Mucoepidermoid and Adenoid Cystic, and then secondary tumors. Now we go into the second topic, updates of the WHO Blue Book. As we know, the WHO Blue Book has been revised 3 years ago, but you should know the Milan system come in 2018, January, and the WHO updates are in 2017, but they have overlapped discussion, and they have overlapped editorial members. So you can know, we take about 12 years to have a new book, a blue book, and the interest part of this blue book is the joint of implication on cytology. So in most of the chapters and most of the entities of this blue book, you can see they have cytology comments in each of the entities. So this is very interesting of this head and neck blue book. In the other blue books, they don't have this implication on cytology, but in head and neck blue book, we have these parts in most of the entities. And this blue book also joined, a lot of molecular, testing. Most of the molecular testing from pleomorphic adenoma, CAX, pleomorphic adenoma, myoepi. Most of the molecular testing are not commercially available. And most of the time we need to do in-house molecular testing. I think the most diagnostic correlation is on the adenoid cystic and secretory carcinoma. Previously, we called this mammary analog and clear cell carcinoma because they have more prevalent and more sensitive, molecular correlation. Especially adenoid cystic carcinoma, they have MIB and MIB-L1 translocational fusion gene in the most of adenoid cystic carcinoma. So this time we did, if you have molecular testing, you can facilitate to pick up the adenoid cystic, especially he has variable patterns. And anyway, I think most of the people don't have molecular, testing at your hand, but I think we should know about the strategies when you are in trouble to divide it into specific diagnosis. And in this update book, blue book, we have 21 carcinomas, 11 benign tumors, and 4 non-neoplastic epithelial lesions, and 3 benign soft tissue entities, and hematoma. And as a plus, it means we have this entity is revised or have new term, such as secretory carcinoma and undifferentiated carcinoma and Sialadenitis. And in this siadoblastoma, previous are classified into malignant category, but now is in uncertainty. And we have some, revised name, such as low-grade cribriform cystic adenocarcinoma. Now is intraductal carcinoma. And previous called as metastatizing pleomorphic adenoma. Now we taken it as a subgroup of pleomorphic adenoma. And as for small or as for large cell carcinoma, now we give them neuroendocrine carcinoma as a group entity. And because salivary gland have a very heterogeneous group, we should know about why the salivary gland tumor is a heterogeneous group. Because from mature axonite to intercalated duct to striated duct to excretory duct, we have different cancers or tumors. For the most mature axonite, we have acinic cell carcinoma. For the intercalated duct, we have biphasic or basaloid tumors, just like basaloid adenocarcinoma, myoepithelial carcinoma, and ADCC, or pleomorphic adenoma, or myoepicarcinoma. For striated ducts, they have columnar and abundant cytoplasm. So we have oncocytic tumors and Warthin tumor. For the excreted duct carcinoma, excreted duct, we have salivary gland duct carcinoma and Mucoepidermoid carcinoma. They are mostly, more larger and more, pleomorphic, especially the salivary gland duct carcinoma. And for the patent diagnosis, I think Sam or Songpoon may prefer the cytology patent diagnosis, because if we see the patent is basaloid, we can see, in the benign category, it can be pleomorphic adenoma or basal cell adenoma. For malignant category, we can, about basaloid patent, we can consider about the basal cell adenocarcinoma or adenoid cystic or polymorphous adenocarcinoma. And subsequently, we have different patents about the oncocytic, squamous cell, or clear cell, or stroma fragments of of lymphocyte predominance or cyst-free predominance or spindle cell predominance. So I think the patient diagnosis, today our focus is on the Milan reporting system. The patient diagnosis, you can, as taken as a reading references, especially for we cytopathologists, we use the patient diagnosis very often. Now we come into our main core of Milan system. Milan system is also ex-CIAC cooperative work. As you know, most of our friends, Dr. Bill, Rosie, and Robert, and Dr. Balkan, and Dr. Maria, Daniel, Mark, and Philip, they are also, all co-editors. This is a very big, head and neck editor group. They discuss about the consensus of the categories and then publish book in 2018 January. And why they need to, initiate this head and neck reporting system consensus and editor group, because we need a general agreement and a clinical correlation to define every salivary gland aspiration. We need a general communication, especially general category, to exchange each other's data, especially in different institutions. So they take an online survey, and respondents are over 500. And most of the institution and participation are from academic origin. And these categories come from the agreements of over 95% agreements with now the reporting system. And they appreciate both Romansky and PET stance. If you do PET stain only, it's okay. If you do Romansky only, it's okay. But we appreciate both Romansky and PET smear are essential slides. If you have dry and wet, it's preferable for diagnosis. And for the Milan system, we can see they have 6 categories. One is non-diagnostic, second is non-neoplastic, third is AUS. The fourth have 2 groups. One is benign neoplasm, one is uncertain malignant potential, we call it SUMP. And the category 5 is suspicious, category 6 is malignant. And you can see the proposed risk of malignancy. The highest one is on the malignant and suspicious. The lowest one is on the benign neoplasm. So back to our, back to our core spirit. Why we need to propose this one? Because we need the management. For non-diagnostic or non-neoplastic, we need to repeat FNA or follow-up. But for AUS, we need to do the surgery or repeat FNA. If you can repeat FNA, do the surgery. Because even AUS may have malignant rate up to 20%. But for benign neoplasm, their malignant rate is lower than 5%. So you can do follow-up or even just an excision for the benign neoplasms. For SUMP, we found even the malignant rate is up to 35%, we still do limited surgery. And for suspicious and malignant, we do wide excisions. Okay, let's go through the Milan 6 categories. The first category is non-diagnostic. Non-diagnostic means it cannot yield diagnostic evidence in this sample. Currently, we have no criteria in literature or in this book to define what is insufficient. But by qualitative or by quantitative criteria, we should know by the quality, if the quality cannot accept it, or the quantity is not equal or appreciate to make a diagnosis, you should put these samples with a non-diagnostic diagnosis. We hope that the non-diagnosis can less than 10% of all the specimens, but it's hopefully because It totally depends on the, the skill of clinical doctors and radiologists, and the preparation and the collection of clinical doctor or our cytotechs. So anyway, the technical problem, the collecting problem, the transportation problems can make the sample into non-diagnostic. So if you are a high quality institution, you can look forward yourself and push yourself to make a non-diagnostic make a non-diagnostic sample less than 10. The exceptions are only matrix, mucoid matrix, or high-in matrix, or only acute information if clinical is abscess or any atypical cells. And someone will recommend to have at least 60 cells as a least adequacy. And if you don't have adequate samples, we recommend to repeat sampling. The Milan 2 is a non-neoplastic. Non-neoplastic means you will have confidence it's not a tumor and it's reactive, such as granulomatous Sialadenitis, or a stone, or intraparotid or intracellular gland lymph nodes. But sometimes even it's non-neoplastic, we still need to take excisions, especially you cannot conclude it's neoplastic or not. So in some subsets, we need to confirm. And especially for the lymph nodes, if the lymph nodes are clinical multifocal and the patient is old age, because reactive lymph nodes is always in young age, and even have exposure of infectious agents. But if the patient is very old or more than 50 years of age, and the clinical presentation is a multifocal lymphadenopathy, you should do the flow cytometry from the aspirates and even the further excision to make a precise diagnosis. This is the picture of chronic Sialadenitis. You can see the background is inflammatory background. You have debris, you have some degenerative salivary glands, and you have some preserved salivary glands. But generally, they are, normal population with inflammatory backgrounds. And granulomatous Sialadenitis, they have vague epithelioid and spindled granulomatous lesions with background of chronic inflammatory cells, and sometimes maybe some debris. And about the non-diagnostic and non-neoplastic categories, we need to mention one lesion. This lesion is cystic lesions. Cystic lesion in several glands is not uncommon. It's very common. That can be from non-diagnostic because you only get the fluid contents, or can be cancers because they have tumor necrosis. So it's cystic necrosis, and you expect to have necrotic and degenerative contents. So about the cystic lesions, we were, in most of the article and in this book, we will recommend to divide it into mucinous and non-mucinous type firstly, and then go on lymphoid and non-lymphoid category. Because express from non-mucinous cystic contents may be pretty watery and may be very easy to put into non-diagnostic cystic contents. But sometimes when you see some, a weird cell and atypical cells, you can also put them into the AUS. And about the express of mucinous contents, it probably a low-grade Mucoepidermoid Carcinoma. It also can be mucocele. So the mucinous content should be apart from the non-mucinous. This is the algorithm the experts propose especially Liron and Rossi, proposed this algorithm in head and neck pathology. Is very famous pathology journal, although the impact factor is not so high, but most of the head and neck pathologists will read the articles. The algorithm is from this. You can divide the cyst lesion into mucinous and non-mucinous. And mucinous, you can see maybe they are mucocele, or maybe they are low-grade mucoepidermoid. But anyway, they are mucinous predominant, so sometimes not very easy to divide them in the very beginning. So if you can only see weird atypical cells, you can also code it AUS. If you can see nothing, only mucinous contents, you can, divide them into non-diagnostic or neoplastic, but only cystic content. About non-mucinous, you should further divide it into lymphocytic lesion or non-lymphocytic lesion. For lymphocytic lesion, as a non-neoplastic condition is lymphoepitheliocyst or Warthin tumor, because predominantly Warthin tumor has cystic contents, but non-mucinous lymphocytic backgrounds. But if non-lymphocytic, you should consider inflammatory cyst or metastatic squamous cell carcinoma. So this is the examples of different category may have different cystic problems. So the cystic lesion in several gland is a big issue, not always benign. You should consider they are mucinous or lymphocytic, and the underlying, the underlying entities you may encounter. The Milan 3 is AUS, just like the previous international reporting system for serious fluid cytology. The AUS in Milan for the several gland tumor is also for a fixation issue or for the preservation issue or sampling issues. So most of the time the AUS reflects the sample issue, because we can see some atypical cells with morphological atypia. Maybe we prefer to put them into non-neoplastic, but we are not sure they are not neoplastic. So atypia is for this condition. And in my tips, I want to say, AUS is low grade. If you can see very high grade atypical cell, please don't put it into AUS. You can upgrade them into suspicious, because AUS is in most of the time, they have mild to moderate atypia. If you have very ugly pleomorphic nuclear atypia, and even with some debris in the backgrounds, you should always keep into alert about, wow, it's mostly not a reactive process. It may be a neoplastic process, especially for high grade. So AUS, I recommend to put into, if you have a typical cell with low grade atypia, or you cannot classify this atypical cell into neoplastic, but you still worry about these atypical cells because you're not sure they are repair or non-neoplastic condition, you can use AUS. So it's a very heterogeneous category from the metaplastic change over to a true neoplastic scenery. So AUS, I think that's why his ROM may be up to 20. And why we need AUS? The AUS can reduce our number of false negative, because for false negative, the false negative category are benign neoplasm and non-neoplastic. These two categories are our benign categories. We need to reduce their false negative rate. So anytime if you consider a typical cell with low grade, but they are not cellular, you cannot put them into totally confident into benign neoplasms because not cellular, or into non-neoplastic because their atypia, you still worried, you can put into AUS. The AUS significance maybe, as I mentioned, reactive atypia, poorly fixation, poorly sampled neoplasms. So they are mostly low grade and sparse in cellularity. The ROM is only 20, and we recommend to use it limitedly. You cannot use it very often. You can only use it in the borderline cases, because a waste of AUS will create clinical problem. And the AUS cytological criteria may be, if you see the squamous, oncocytic, or metaplastic changes, you cannot define as a neoplasm. And generally, it's low cellularity, not cellular, because a cellular sample, we will put them into neoplastic, either benign or SUMP. And then the preparation artifact is remarkable. You can also put into AUS. And mucinous cystic lesion, you have predominantly mucinous matrix, but the epithelial parts are very few, and the atypia is low grade. In this case, you can also put into AUS, even it's probably a low-grade mucoepidermoid carcinoma. But you have very few case atypical cells, so you can put into AUS. And about the lymph node and lymphoid lesions, if you cannot show they are lymphoproliferative disorder, you cannot exclude a low-grade lymphoma. You can also put into atypical uncertain significance. Okay, let's show some illustrative pictures. About in the background of lymphocytes and the degenerative cell, you can see pretty enlarged and pretty atypical cells with cytoplasm and multinucleated giant cells in the background of ductal cells. And these kind of cases are very scattered and very few, but you still worry about these rare atypical cells in the background. So you can report them as AUS. And about this group of epithelioid cell, maybe granuloma, maybe tumor, anyway, if you cannot decide these epithelial cells are truly a granuloma or truly tumor, because it's most three-dimensional, and the background is not too inflammatory, it's pretty cellular, this kind of case, you can put it into AUS. And sometimes in the background, of lymphocytes, you can see scattered oncocytic cells. Maybe you can consider Warthin tumor, but the epithelial oncocytic cells are pretty scattered, pretty rare. In this case, you can also put it into AUS because you didn't have cellular oncocytic fragments in the background of lymphoid backgrounds. So you don't have confidence to call it oncocytoma, oncocytic carcinoma, or or Warthin tumor, or oncocytic variant of Mucoepidermoid carcinoma. Anyway, your epithelial contents are limited, so you can put it into AUS. And sometimes you get a pretty, poorly fixed or poorly prepared fragments, and in this hypocellular express, you see they have, Myoepithelioma, and the preservation is pretty ugly because the quality is not so good. In this kind of scenery, you can also put it into AUS because it's low cellularity, but the cell is not so, is not so satisfactory for, a benign diagnosis. So we put it into AUS. And about this case, you can see is a bloody covering bloody cell hinder the epithelial fragments. The epithelial fragments are generally low grade and minimal atypia of oncocytic or epithelioid fragments, but they are hindered in the background of the blood cells. So it's not easy to read in this time because the technical problem or the artifacts, you cannot read the cells very well. You can also put it into AUS. And in this scenery, you can see mostly are mucoid matrix. You cannot easily to see cellular fragments. In this case, maybe mucocele, maybe low-grade mucoepidermoid, but you cannot confidently to cite it as non-neoplastic. So you put this into AUS. And in this condition, you see a group of squamoid keratinizing squamous fragments. It could be a squamous metaplasia. It could be a squamous cell carcinoma. Anyway, you cannot confidently cite it as something. So especially when a hypocellular sample, you can cite it as AUS and mention about the squamous, atypical squamous cell in this sample. And for lymphoid aspirates, of lymphoid lesion aspirates, if you can see multi-populational distribution, is generally as a benign condition. If you have large and small and medium, and even PMN cells, neutrophilic cells, is more suggestive as a reactive process. But as in this picture, we also see some lymphoglandular bodies, and especially the background is a bit dirty. If you have no confidence to cite it as benign reactive process, you consider about the possibility of low-grade lymphoma. You can also cite it as AUS. So in all this scenery, you can have one concept about AUS. AUS is a diagnosis to fulfill heterogeneous condition of different diagnoses. Okay, let's go into the Milan 4.1, benign neoplasm. The benign neoplasm, this category has the lowest rate of malignancy in Milan system, less than 5. A benign neoplasm must be a cellular specimen with characteristic subgroup. For example, mostly are pleomorphic adenoma and Warthin tumors, and lipomas and schwannomas, such as this. So it's cellular, and groups are very characteristic. You have confidence to cite it as neoplasm, especially the clinical also hint or suggest it's a tumor-like lesion, and you have a cellular specimen, and the specimens are characteristic for PA, for Warthin, for lipoma, for schwannoma, and that's why we call this benign neoplasms, because the diagnosis is no questionable. So the PA, the benign mixed tumor, is the most diagnosis occur in this category. It may have a fibrillary chondromyxoid stroma, and this fibrillary chondrosarcoma is more, characteristic at the dry stance, to be a metachromatic at the dry stance, and gray to blue on the PEP stance. And it has mixed ductal cell, cuboid, polygonal cell, and epithelioid cells, and plasmacytoid cell, and plain-looking cells. So I think everybody is very familiar with the diagnosis of pleomorphic adenoma. He can have a pretty cellular or epithelial contents, or pretty cellular or stromal contents. Is variable, variable contents. So sometimes you can see both of the biphasic pattern. Sometimes you can see the spindle predominance fibromyxoid change. Sometimes you can see the epithelial contents with predominance epithelioid or plasmacytoid cells. And sometimes you can see the stroma and the more basaloid epithelial cells mixed together. And the only pitfall for pleomorphic adenoma may come from the carcinoma XPA. Is 80% occur in the major gland. So when you express the major glands, especially for long-standing PA for all patients, you should always keep in mind it may have something wrong, especially for all patients. For cellular specimens, especially predominant with epithelial cells, you should always find the epithelial atypias because the malignant component may be from adenocarcinoma, salivary duct carcinoma, always high grade, ACC, mucoepidermoid, or pleomorphous adenocarcinoma, or epimyoepy. It has various carcinoma XPA. So look at the predominant epithelial contents. And then the Warthin tumor, because the Warthin tumor is very easy to pick up, you can see about the biomorphic population of lymphocytic and oncocytes. So the most differential diagnosis will be occur in mucoepidermoid carcinoma, oncocytic variant, and oncocytoma, and sometimes with intraparotid lymph nodes or squamous cell carcinoma. This is the characteristic of Warthin tumors. You can see the oncocytic cells as the solid sheets and background of lymphocytic predominantly background. And sometimes Warthin tumor, you can have a typical squamous metaplasia, especially after aspiration and with tumor infarction. You can have this kind of squamous metaplasia and a necrotic background. In this scenario, you are very easy to mimicking squamous cell carcinoma, create a false positive diagnosis. You can read this kind of manuscript in the published articles. Myoepithelioma have sometimes a very overlap diagnosis because they have two cell types, spindled and the plasmacytoid cell can present in a same tumor. And they may have collagenous stroma, chondromyxoid stroma, and look like PA, but without ductal cells. So myoepithelioma, as my opinion, when I see plasmacytoid and spindle, and the stroma is relatively more chondromyxoid or collagenous, I will consider about the myoepithelioma, especially plasmacytoid predominant. But we cannot see too many lymphocytes or ductal cells. So I don't consider PA or Warthin tumor, but I will consider myoepithelioma. For the SUMP is very big issue in Milan system. So you can continue to read about the articles for the SUMP. The SUMP diagnosis we should always keep in mind is for a low-grade lesion. A SUMP should not, in most of the time, should not recruit a high-grade morphology neoplasms. If you have a high-grade atypia neoplasms, you should put it into suspicious for malignancy, not in SUMP. SUMP is a diagnosis for intermediate and low-grade neoplasms, such as myoepithelioma or stroma poor. It means cellular pleomorphic adenoma, or Warthin tumor with a typical metaplasia, or basaloid tumors. So it should be cellular, but the cellular parts are intermediate grade or low grade. That's why we call it SUMP, because it's uncertain malignant potential. If it's high grade, we don't put it into uncertain. The SUMP subgroups have basaloid neoplasm and oncocytic neoplasms and neoplasm with clear features. And most of the time, most of the experts will focus on the basaloid and oncocytic neoplasms. The basaloid neoplasm may have fibrillary stroma, especially in PA, myoepithelioma, or basal cell neoplasms. Hyaline stroma with ADCC and pleomorphous adenocarcinoma, epimyoepy, or mixed stroma in ADCC and polymorphous adenocarcinoma, and scanty stroma in ADCC, cellular PA, and the canalicular adenoma, myoepithelial carcinoma. In these two pictures, you can see the hyaline stroma and the scanty stroma. Both of the neoplasms are ADCC. ADCC have very various patterns of stroma. The cellular oncocytic tumor may cover with benign Warthin tumor, oncocytic cytoma, to acinic cell carcinoma and memory analog secretory carcinoma. Now we call it secretory carcinoma, or metastatic RCC, Mucoepidermoid Carcinoma, and Myoepithelioma, and the clear features. This is a book table. About the ADCC I just mentioned, is is an old stage disease and mild female predominant, and most of the lesion are has a basaloid picture with small to medium cell and clear to eosinophilic cytoplasms, cohesive cellular clusters, and high NC ratios. ADCC sometimes is difficult to distinguish from the other several gland neoplasm, especially they don't have metachromatic stroma, just like here. That's why most of the people love to see the cribriform pattern, because the cribriform pattern have metachromatic stroma, very characteristic. But in the absence of metachromatic stroma, it's not easy to diagnose ADCC. The differential diagnosis include the PA and other basaloid neoplasms. You can, if you have cell block, you can use KIT. And if you have molecular testing, you can use the molecular testing to detect the MIP1, the MIP and the MIP-L1 transfusion proteins. This is the cytology pictures of the ADCC in various cases. For sure, most of the diagnostic picture is going to cribriform patterns. Acinic cell carcinoma is majorly occur in parotid glands, and it's very slow growing. So mostly is in older patients, and it's usually high cellular and loose axonal structures, and usually it has bare tumor nuclei. It means the nuclei will be naked or degenerated in the backgrounds. And if you can, prepare very good dry stains, you can see the granular vacuolated cytoplasms. And the ACC has a diagnostic issue about very high false negative rates, because the ACC mostly may mistaken as the normal several glands. But if you see the clinical study has mentioned a tumor mass, and you got a lot of mature acinic type cells, you should consider about acinic cell carcinoma. And especially he has no specific IHC profile or genetic testing. This is the ACC. You can see most of the cases are mono population, and the cell size are relatively not large, and they are monotonous, and the cytoplasm are ample, granular, and even somewhat clear. So in a dry stain, you can more easy to see the granules. The Milan flag is for the suspicious for malignancy, especially apart from SUMP. For the suspicious for malignancy, you should recruit cellular sample with high-grade morphology. Okay, why not it put into the positive for malignancy? Because the cellularity is not so adequate to put into positive. So it's high grade. to put into suspicious for malignancy, but cellular or not is not important. So if it's pretty cellular, put into positive. It's just high grade, put into suspicious for malignancy. So this category is for high grade carcinomas, and the ROM is around 60%. The characteristic diagnosis for suspicious for malignancy is salivary duct carcinoma. It's pretty high grades. The cytology picture of high-grade adenocarcinoma with necrosis and mitosis. It can be cribriform, papillary, or sheets, or single cells. But anyways, like a breast cancer metastasis. So you can see abundant epithelial cells, and the nuclear atypia is pretty ugly, pretty remarkable. And the background shows some debris. But anyway, the morphology should be ugly. So it's very important to keep in mind, suspicious high grade, SUMP low grade, they have a big difference. Mucoepidermoid carcinoma is another issue because for SUMP and for suspicious for malignancy, because they have low-grade mucoepidermoid carcinoma and high-grade mucoepidermoid carcinoma. If high-grade mucoepidermoid carcinoma, you can see squamous nests and more high-grade nuclear atypia. So easy to put into suspicious for malignancy. But for low-grade, sometimes they may be only mucoid cystic contents, so may be put into only AUS. So sometimes low grade can put into AUS or SUMP. Mucoepidermoid carcinoma have three types: mucous cell, intermediate cell, and epidermoid cells, and their condition can be only mucinous or high grade with debris and ugly nuclear atypia. So it's a variety of the cytology pattern. Okay, for so many several gland neoplasms, we still need to do some immunostats if you got adequate samples. But most of the time, we just use to guide us to put this into some diagnosis further. For pleomorphic adenoma, you can see the positive marker, especially recommended as PLEG1 HMGA1, HMGA2, ADCC for MIP positivity, and basal cell adenoma or carcinoma. They have beta-catenin overexpression and LEP1 positive. And for ACC, DOG1 strong staining can be a hint, and SOX10 also positive. For oncocytoma, negative marker is DOG and SOX10. And now I want to special mention the SOX10. SOX10 we usually use it as a melanoma marker, but in several gland neoplasms, we can use SOX10 to divide them into two groups. One group is positive group include ACC, ADCC, and epimyoepy, myoepithelial carcinoma, and pleomorphic adenoma. And negative group is oncocytoma, Warthin, and mucoepidermoid carcinoma, and salivary duct carcinoma. So SOX10 sometimes can be, have a dividation to different groups. If you have, challenging judgments in, between each other. Okay, next I want to show two cases. Case one is a 65-year-old female. It's a well-defined hypoechoic vascularized mass in left parotid gland, and clinically suspicious for polymorphic adenoma. The X-rays, yes, you can see it's lobular solid sheets, monotonous cells, and have some, cuboid or columnar, and some flat cell around it. And they are, the cytology, morphology are pretty minimal atypia and pretty bland looking. The cytoplasm are granular. In dry stain, you can for sure to make they have a pale eosinophilic cytoplasm, and the nuclear variety is minimal. So in my opinion, I will put into oncocytic neoplasms. But the background didn't show a lot of lymphocytes. So I prefer oncocytoma, oncocytosis, or oncocytic carcinoma, anyway, oncocytic neoplasms. So in my choice, I will put into maybe benign or SUMP. And after excision is oncocytoma. Oncocytoma is occur in the middle to old age and have no sex predominance. 2% of all cerebral gland tumor and mostly solitary. And if you see it multifocal, you may be oncocytosis. And exclusively oncocytic cells with granular cytoplasm. Atypia is minimal. And the second case is a 63-year-old female. Also, it's a superficial lobe left parotid gland. It's a small tumor, but you can see, although it's a small tumor, but the aspirates are pretty cellular. And you can see some binucleatic cells, some epithelioid cells, but you can make sure the cytoplasm is pretty, pretty eosinophilic or granular. And some cases are maybe plasmacytoid. And you can see some papillary-like structures. But the atypia is no high grade. So it's for sure it's a neoplasm. But how about put it into benign neoplasms? I'm not confident. I may put it into SUMP. And in the dry stain, you can see, wow, the granular cytoplasm is very characteristic. And this is the cell block. You can see some, eosinophilic cytoplasm and gland-like structures, and exclusively oncocytic lesions. So another oncocytic lesions, but the atypia is much higher and much more remarkable than the previous one. And the papillary structure is again to increase our worrisome. So I will put this into SUMP. And then after excision, you will see, wow, it's invasive cancer. And the invasive cancer have quifiform or breast-like structures. Just like a breast cancer, you have tubular structures, you have some nucleolus, you have pale cytoplasm with granular cytoplasm. So it's a secondary carcinoma. The secondary carcinoma sometimes, very easy overlap with oncocytic lesions, but the big hint is the papillary structures will be more common, and luminal structure of and intracytoplasmic mucin can be found, and very easy to put into SUMP. Or if you see the high-grade pictures, you can put into suspicious. And if you have cell block, you can do the ETV6 anti-RK3 gene fusion. Exclusively is a marker for its gene fusions. So if you have immunocytochemistry, you can do X100, myoglobin, and DOC1 negative, and mostly are triple negative. So secondary carcinoma is another, big differential diagnosis in oncocytic neoplasms, especially he has specific molecular testing. Conclude about this talk is you should make sure the WHO Blue Book, every entity has cytology criteria and cytology implications, and make sure your tumors about low grade and high grade. High grade put into suspicious and malignant. Low grade put into SUMP, or even benign, or even non-diagnostic. And immunoprofiles for the cell block sometimes may be a good external test for further classifications. If you have ADCC or secretory carcinomas or clear cell carcinomas, you can do some molecular testing if you have available molecular testing. And thank you. I really look forward to your visiting and my visiting to Thailand again.